Thank you, A.Shanmugam. Thanks, Mohan sir and team, and thanks for this opportunity. These are my disclosures. I've been not contracted for this talk, and I acknowledge presence of my mentor, Professor Shashank Joshi sir at the back, and I am surprised that Ranjit can talk in front of Anjana, and that's something to be appreciated. I think you should give me a round of applause. I has been talking in front of me. Okay, now I understand why you could talk. Thank you. And my topic is, of course, DPP4, whether they're relevant in Indian context. I have got little emotional attachment to the DPP4s because my clinical trial journey started with sitagliptin in about 2004-5. That was one of the first clinical trial, which was called MK0431. I still remember the name of the molecule. There was no name given. It was only the code. So in that way, I am really attached to the DPP4s. And when first time they came, we were so amazed by the mechanism of action. And of course, to begin with, the Asian Indian phenotype, all of us are aware about the thin fat Indian concept and the early decline, higher insulin resistance and higher risk of diabetes in our Indian context. So we as clinicians in India face a different ball game because the diabetes in India is quite different. We have a higher insulin resistance, strong family history, which pushes most of us into this bracket of diabetes, and diagnosed very young, suffer at very young, and early onset of diabetes complications. And of course, sedentary lifestyle and thin fat Indians is something which is there. So the unmet need in diabetes management is, of course, the beta cell declining, increasing in these parameters, and of course, current therapies are mostly associated with the complications of hypoglycemia and of course, weight gain. Just to show you the global burden on the CKD in diabetes is about 10%, and nearly 36% patients with DKD result with persistent albuminuria, reduced eGFR, or both. Now, why I am emphasizing on this aspect is because this is something which is a bedside test which most of us do not do the strip test, at least the spot test for the urine microl. And we know that diabetes is the most common cause of ESRD in our country, which accounts almost to 50%, to the tune of 50%. And of course, risk of diabetes related CKD observed much higher in our Asian countries than the West. And just to show you the Indian scenario, about 697 million cases CKD in the world, nearly 16% are in India, and prevalence of CKD in Indians with diabetes is about 50%. 3 times higher renal and all-cause mortality is seen in our country. So that is something which you should know, the burden. And of course, Indians have twice the CVD mortality and 3-fold higher kidney and all-cause mortality. 3-fold, that's something you should remember, and this is what I'm just trying to show. And nearly 1 in 2 heart disease deaths among the Southeast Asians with diabetes versus 1 in 8. So that is the frequency of this problem, and I'm sure all of you are aware why I'm talking about the CKD background in the gliptin talk, because one of the gliptins can give you that advantages, and Indians are mostly susceptible to diabetes and CVDs, and they have twice the CVD mortality at a very young age and all-cause mortality also. So this is something we should remember when we are treating our patients. Now this is about the impaired kidney function, just showing the relationship, causal relationship with the CV outcomes in diabetes, and that's something we should remember. The 4-point MACE events are increased with lower baseline eGFR in Indians. That is something again you should remember. This is only typical of Indian set of patients. So the issues to be addressed are the impaired insulin secretion, the beta cell progression, dysfunction, disrupted incretin response, dysregulated glucagon secretion, and of course ultimately it's insulin resistance. So we do have these ethnic differences in secretion and metabolism, these incretins. Now what is that? That is why the DPP4s are very relevant in our context. So ethnic differences may be attributed to significant difference in the fasting glucose stimulated GLP-1s among different races. And in Indians perspective, that is Asian perspective, data are even more conflicting as significant differences in the total GLP or the intact GLP and the GIP, which have been observed in some studies. So the total GLP-1 levels in Asians also varies from low to normal, and that is where the talk is about the gliptins, whether they are relevant in Indian context. So the young healthy South Asian showed higher GLP-1s and higher insulin levels, and that is what is insulin resistance after a glucose load when compared to the Caucasian counterparts. So that is the basis of the DPP4s, why they work better in Indian context, and the most prominent advantages in routine clinical practice where we use the metformin sulfonylurea combinations highest, but this is a non-glucose dependent action of SUs versus glucose dependent action of DPP4s, and that's the best part to prevent the hypoglycemias, and that's the greatest advantage in routine clinical practice to negate the hypoglycemias. So when we manage these patients with diabetes, the treatment selection has to be very methodical because it is to be countered by calculating these many factors in our busy OPD about the variable expectancy of the efficiency, the weight control, hypoglycemia, and monitoring to prevent hypoglycemia, associated comorbidities, of course cost in Indian context, again out of pocket market, and the polypharmacy and the adherence. You know, after 3 drugs, if you prescribe the 4th, 5th, the compliance comes down by about 8% for every tablet. That means if somebody is on 6, 8 tablets, their compliance is only about 50-60%. So that is where the problem comes with the polypharmacy and of course the dosing and timing. And these challenges are most common causes for resistance of changing the therapy. Now the DPP4s definitely addresses this unmet need in the management of diabetes because the physiological levels of GLP-1s, where the multiple effects on the plasma glucose in the form of insulin resistance, inadequate glucose suppression also taken care at the level of the alpha cells, the acute beta cell function, and of course the chronic beta cell function, all these places the DPP4s have role. So they augment the circulating GLP-1 levels which can target the islet cell dysfunction. So that is why the increased DPP4 enzyme activities are found in Indians. This is a clear-cut evidence where non-obese Indian patients with diabetes have the higher values of circulating DPP4 levels, which correlates with all the markers of your obesity. You can see the waist hip ratio, the total intra-abdominal adipose volume, liver span, fasting insulin levels, low density LPA, tricep skin fold, the intra-abdominal adipose tissue volume. All these are correlated positively with the DPP4 activity. And this is another slide which talks about the efficiency of DPP4 higher in the Southeast Asians compared to the non-Asian population. This is again the effect of DPP4s, which are, it's a meta-analysis results what you are showing. So the DPP4 inhibition enhances the physiological effect of the incretin hormones, whereas your GLP-1s, the GIPs give you the hyperphysiological or super physiological values, whereas DPP4s gives you the physiological elevation. Now the role of adiponectin and its relationship to the incretin response in Indian context. Adiponectin is from the adipokines and secreted exclusively by the adipose tissue. We know the root cause or the common soil hypothesis, inflammation, and then the dyslipidemia and the ectopic fat deposition in all these cells, where it has got a putative insulin sensitizing, anti-atherogenic, anti-inflammatory properties. The total serum adiponectin concentration is inversely proportional to both visceral fat and insulin resistance. Again, this is very typical of our Indian context, and that's how the DPP4s play an important role in Indian context. So low adiponectin has been found to predict the future development of this incident type 2 diabetes in various populations. There are evidences. The long-term DPP4 inhibitor treatment will likely elevate the serum adiponectin levels and in turn reduce the insulin resistance in Southeast Asian population. Again, there is an evidence for that. So this could be the possible another mechanism by which these incretin based therapies might modulate different responses in Indians and non-Asians and Asians. So the era of gliptinization started way back about 16-18 years back, and in many ways they have changed the way the diabetes and its management has been taken care. Especially that was one of the first gliptins were the first class of drugs after your SUs and metformin, which we all used to be, and it addresses 6 out of 8 pathophysiological defects, the Omnes octet what we call. You can see literally all these places except in the kidneys and in the brain, all the other 6 places it can take care, apart from you can see the other drugs are SGLT2s and the GLP-1s and of course metformin in some places. So it has got effect on both alpha and beta cells, and that's how it can suppress the glucagon release, enhance the glucagon release in response to hypoglycemia because it's insulin dependent action, and it improves the alpha cell sensitivity apart from resisting the apoptosis, inducing the beta cell proliferation, stimulating a glucose dependent secretion of insulin. So the potential impact of DPP4 inhibition and the incretin system on various organs are clearly showed here. For want of time, we will not get into this, but literally 6 out of 8 Omnis octet is tackled. Of course, the ADA 2024 standard of care clearly talked about the SGLT2s, the GLP-1s, which demonstrated the CV disease benefits, and it is recommended for established ASCVD or patients with high risk. And this was one of the earliest trial which talked about the cardiovascular death benefits, the MACE events reduction by 38%, and that is change our game. But remember, the need remains for additional glucose lowering agents with a demonstrated efficacy and long-term CV and kidney safety profiles, because we are not treating with, the story does not end only with the SGLT2s and the GLPs. So DPP4s are the most common treatment option for diabetes because they are weight neutral, hypoglycemia is very minimal, well tolerated, long experience, we have about 2 decades now, and of course cost benefits, especially in the Indian context. This is just to show you the renal impairment and the DPP4 roles. All of them can be given except the linagliptin, which is very safe. Teneligliptin also can be given, but it's almost out of market now. But linagliptin is something which is safer in this kidney background, but Sita, Saxa, Vilda also can be given with a dosage reduction with a moderate and severe. Of course, below 30, only linagliptin is given. And of course, this is in the hepatic dysfunction. Again, you can see the numbers there very clearly, mild, moderate and severe hepatic failure. The dose below in the severe form, they are not recommended in general. Now the linagliptin has got the highest DPP4 inhibition potency compared with the other globally variable DPP4 inhibitors. That is well established, we know that. And of course, the selectivity again matters. There is something called DPP8 and DPP9 also, and Lina has got a little more inhibition rates towards that, and that's how they have this implications in this preclinical toxicities and suppresses the T cell activation and proliferation. And of course, the information that Lina is one of the globally available DPP4 inhibitor with the lowest kidney excretion rate, and that's how it is safe, because only 5% is excreted through the kidney. So DPP4 perspective, A1C reduction is at par with SUs, which is again proved in a massive randomized controlled trial. Carmelina corrects the basic pathophysiological defects of type 2 diabetes. As I said earlier, 6 out of 8 Omnis octet is tackled. Minimal hypoglycemia risk, weight neutrality, pleiotropic benefits, and of course it has got adverse events of pancreatitis and nasopharyngitis, which you should keep in mind, and CV neutral. Let's look at the long-term trials with the DPP4s. We had TICOS with Sita, we had Savior Timi, we had Examine, we were part of Examine alogliptin, and Carolina, which is linagliptin versus glimepiride, and about 6,000 plus. Carmelina and Carolina put together, I think it were about 12,000 patients with a span of 7 to 8 years. Now this is what is the advantages with these drugs. Sita did not increase. Savior Timi had little heart failure signalization for hospitalization for heart failure, and that's how it almost went out of the market. Alogliptin again safe, and vildagliptin is not associated with the increased risk of MACE events. So these are all the evidences. They are cardiac friendly, at least they do not harm. So that's the message based on all these published RCTs, except Saxa, which increased the signal for heart failure. Otherwise, they were all safe. So the CV and renal outcomes with the DPP4s, you can see the linagliptin is the safest emerged in the background of the renal outcomes. Of course, teneligliptin do not have the CVOTs. And this is quickly about Carmelina and Carolina, 6,000 plus 6,000, roughly 12,000 patients, a robust CVOT trial which demonstrated the long-term safety profile of the DPP4s per se. And that is where this is very important, that we have one of the longest and the largest studies to talk about the advantages of DPP4. And learnings from this, we know 14% relative risk reduction of the progression of albuminuria, 15% likelihood of reduction of significant regression in the USER, and the long-term glucose lowering efficacy is definitely comparable with the glimepiride. Now, this is a very important slide where it is vis-a-vis compared for 2 years with the glimepiride and shows persistence and reduction because we normally think SUs are very powerful, but linagliptin has got up to the point of 0.8% reduction of A1C is also there with linagliptin. Please do not forget that. and with a lower risk of hypoglycemia. That's most important. This is just to show you that more patients achieve the target A1C. You can see the inside one, the 54%, talks about people at the end of 2 years had the lesser hypoglycemias with a 54% reduction. That's what it says compared to 23%, which talks about the beta cell exhaustion also over a period of 2 years. Very clearly shown there, 23 versus 54%. So the mechanisms are definitely complicated, and it is of course rooted through the DPP4 inhibition only. And the renoprotection is supposed to be from the improvement in the renal histopathology and albuminuria reduction. It is mainly driven by these two segments, and the efficacy of gliptins in this DPP4 inhibitors have the potential to improve the glycemic control in patients with that is where you need to be very clear about. You can see all the molecules mentioned in the bottom, and several trials have shown up to 54 weeks duration were retrieved, which included one study on these molecules, and the A1C lowering effect from a given baseline was similar with these. And this is what it talks about the glycemic variability. Again, we talk about this, and this is one of the trials I'm showing with the vildagliptin, which could show better circadian glucose control than in sitagliptin with a significant decrease on overall hyperglycemia, mainly driven by the reduction of the hyperglycemia. Now you can see another trial, vildagliptin add-on to insulin therapy, nocturnal glycemic variations in uncontrolled type 2 diabetes, CGM data, again very clearly showing the advantages with that. And this is a summary of 2-year data about the efficacy and safety of DPP4s added on to metformin versus sulfonylurea in diabetics. You can see the baseline A1C and 104 weeks, and you can see the percentage of hypoglycemias. You can see the results. DPP4 as an add-on to metformin, definitely superior to sulfonylurea metformin combination when it comes to the efficacy and the safety in the form of hypoglycemia. Of course, newer gliptin, this is one of the newer gliptins which has come up, trilagliptin, which is just launched I think this year. It's synthesized using the latest molecular design technology, structure-based drug design, by which this hydrogen in the benzene ring, which is supposed to be existing in the DPP4, allogliptin, has been substituted with the fluorine. That's how it has got that 1 week, weekly once DPP4. And these are which are in the drug development, the dutagliptin and gosogliptin, which is their short acting, both are, and it has to be once daily. Of course, they are now at the phase 3 level. Now, before we stop, you see the minimized hypoglycemia category, which is there in the middle, which Ranjit was expecting that to be metformin to be there, but the DPP4s are already there at that category in the middle. And of course, whenever a patient comes, you need to look into these factors about the efficacy, hypoglycemia, the weight change, CV, neutrality, cost, and of course, the route of administration and the renal safety, and what are the adverse events. This is how the category, and you can see the DPP4s clearly pass most of these categories except for the established pancreatitis you do not initiate. Except that, I think all other things are good to go in Indian context, keeping the cost, keeping the renal and the CV safety. So after metformin, because the talk is after Ranjit, so I had to put this slide, otherwise you wouldn't have allowed me to talk here. So the only class target which can target 6 out of the 8 Omnis octet defects, glycemic variability, CV neutrality, safe to use, minimal risk of hypoglycemia, liver fat reduction, and excellent tolerability profile is something which is there. Again, to emphasize, DPP4s are the most common treatment options in diabetes, weight neutral, hypoglycemia, well tolerated, long experience. So the Indian type 2 diabetic patients, it is managed suboptimally and effective in providing good glycemic control in the form of gliptins, and also gliptins are weight neutral, and the durability is long term. We have enough data now to stay 2 decades of data to talk about the durability, and of course low risk of CV events. Thank you very much for patient hearing.
Thank you, sir.